Welcome, everyone, to another deep dive. Imagine, just for a moment, living with something persistent, a condition, maybe for years. It's debilitating. You have these symptoms that really profoundly impact your daily life, only to be told again and again, maybe it's all in your head. Ooh, or maybe even worse, you get a diagnosis, but it's completely wrong. Sends you down totally the wrong treatment path. Well, that's not just, hypothetical. It's a stark reality for countless people. So, our mission in this deep dive, we want to cut through that confusion. We're exploring 10 specific health conditions, ones that are, frankly, alarmingly and frequently misdiagnosed. We're going to uncover not just what they are, but maybe more importantly, why this keeps happening. We've got a stack of articles, research, expert notes right here. Okay, let's unpack this. Let's get straight into it.
And if we connect this to the bigger picture, the impact, it's profound. Misdiagnosis, it really extends far beyond just the individual patient. It affects their emotional well-being, definitely. Their finances, relationships, often just their ability to live life fully, to work. And it also has these huge ramifications for the broader healthcare landscape. Think about delayed treatments or even completely inappropriate ones, wasted resources. What's fascinating here, though, is our dual focus today. It's not just about identifying these elusive conditions. Crucially, it's about detailing what healthcare professionals can actually do, how to catch them earlier, and what you as a listener can understand to maybe advocate better for yourself or, for your loved ones. So we'll delve into specific symptoms, the subtle ones, often overlooked, common pitfalls in standard lab testing. There are quite a few. And those nuanced diagnostic signs, the little things that, when you spot them, can finally lead to the real diagnosis, shortening what is often a really painful, really arduous journey.
Okay, so the inherent complexity of how diseases present themselves, that's got to be a huge factor, right? Why some things are just so hard to pin down. Here's where it gets really interesting. So many conditions, they start with these incredibly vague symptoms or overlapping ones.
Exactly. Symptoms shared across loads of different health issues.
Think about it like persistent fatigue. Who hasn't felt that? Or generalized joint pain that kind of wanders around, brain fog, digestive upset.
Right. These aren't unique flags for one specific disease.
No, they could be the first whisper of a dozen different things. A simple virus, maybe, or something serious like an autoimmune disorder.
It's like trying to find that specific needle in a haystack, but the whole haystack is made of similar-looking needles.
And that complexity, that vagueness, it's a core challenge for doctors, isn't it?
Precisely. Clinicians often have to rely heavily on what the patient reports, their symptoms, which is absolutely crucial, of course. It's the starting point. But sometimes those reported symptoms, they lack the clear, objective, measurable markers needed for a quick, definitive diagnosis.
So the initial sorting out, the differentiation, that's tough.
Incredibly challenging, even for experienced doctors trying their best. They're piecing together this complex puzzle, often from subjective descriptions. And the human body, well, it's not a simple machine, is it? It doesn't have one clear symptom for each disease.
No, it's this dynamic, interconnected system. Problems can ripple out, mask their true origin.
And this, unfortunately, leads to what's often called a diagnostic odyssey.
Ah, yes, I've heard that term. That sounds exhausting.
It is. It's this long, frustrating, emotionally draining journey patients face when their condition just stays undiagnosed, or maybe worse, mislabeled.
You're talking years.
Sometimes years, even decades, going from doctor to doctor, specialist to specialist, enduring countless tests, getting conflicting opinions, all while they're still suffering.
Just searching for answers that aren't coming quickly, feeling dismissed, maybe unheard, desperate.
Exactly.
So is there a common thread here, something underlying why these odysseys happen?
What's truly fascinating here, and it's a key theme that runs through all the conditions we'll discuss today, it's the critical importance of vigilance and maybe a healthy skepticism, especially when those initial test results come back looking normal, but the patient's symptoms just don't stop.
So normal isn't always the end of the story.
Not at all. This introduces the central analytical lens for our whole deep dive today. We can't just accept a normal result at face value when it flat out contradicts someone's lived experience.
Okay.
We have to understand that normal always has context, a normal range on a lab test. It's often just a statistical average from a generally healthy population. It's not necessarily the optimal level for every single individual, especially someone who is clearly unwell.
So the real clues might be hiding beneath that surface of normalcy.
Often, yes. It's about looking beyond the obvious, encouraging clinicians and patients, too, to dig deeper when the first answers don't quite fit the ongoing struggle.
Right. Continuous questioning, persistent investigation.
That's paramount, to shorten that diagnostic odyssey for so many people feeling lost in the system.
Okay, let's jump into the first condition spotlight, Lyme disease. This sounds like a really tricky one, a prime example of something easily mistaken for more common stuff.
That's a perfect way to put it. A master of disguise in the infectious disease world. The initial symptoms of Lyme, feeling generally unwell, fever, that deep fatigue, joint pain.
Sounds like the flu.
Exactly. Incredibly nonspecific. They closely resemble common viral infections. Flu, a bad cold, which is precisely why it often gets dismissed early on. No deeper investigation.
Your first thought isn't usually a tick bite when you feel achy and tired.
Right. And crucially, that distinctive bullseye rash, erythema migrans.
The classic sign.
It is a definitive sign. But it only appears in some patients, maybe 70–80%.
Only some. Wow.
Yeah. So if that telltale rash is absent, those other vague symptoms, easily blamed on something less serious. And that's a huge missed opportunity for early diagnosis, early treatment, when it's most effective.
Sending patients right onto that diagnostic odyssey track.
So if the early signs are so easily missed, what about the tests? Do they help pin it down?
Yeah, I imagine the testing itself must add another layer of complexity, especially with such varied symptoms.
You've hit on a really significant point there. Serologic testing for Lyme. It's a major pitfall. Adds to the challenge. Standard tests, like ELISA and Western blot, they look for antibodies, the body's response to the Lyme bacteria, Borrelia burgdorferi.
Okay.
But here's the catch. These tests can be falsely negative, especially in the early phase.
Oh, how early?
Within the first few weeks after infection, usually. The immune system needs time, maybe 2 to 4 weeks, for those antibodies to build up to a level the test can actually detect.
Like trying to find footprints before enough have been made.
Exactly. It's like the trail isn't clear enough yet. And on top of that, clinicians might misinterpret the results, or maybe they just order the test too soon.
Which gives a false sense of security. Oh, it's not Lyme.
Right. Even when it actually is. And that early window is so critical because prompt antibiotics work best then, preventing long-term issues.
Okay, so if the early symptoms are vague and the early tests can be unreliable, what are the key giveaways? Are there specific clues, maybe less common ones, that should really raise a red flag for doctors or even for patients who are aware?
What's truly fascinating here is that sometimes the deepest insights come from looking beyond those typical general symptoms. A really crucial clue in Lyme disease is migratory joint pain.
Migratory, meaning it moves around.
Precisely. Unlike many conditions where pain stays put, Lyme can cause pain that distinctly shifts locations, moves from one joint to another, maybe even one side of the body to the other, sometimes within hours or days.
That sounds unusual, not like a typical sprain or arthritis.
Highly atypical for those. It should immediately raise suspicion for a systemic infection. Another specific flag, especially neurological, is facial palsy. Bell's palsy.
Where one side of the face droops.
Yes. Suddenly. While it can have other causes, in the context of other vague symptoms, it's a strong pointer towards Lyme, especially if it happens out of the blue. And of course, you can't ignore a known history of tick exposure.
Makes sense. Even if you don't remember the bite.
Even then. Just living in or visiting an endemic area, the Northeast U.S., parts of the Midwest, areas in Europe that should prompt a closer look. So when someone presents with persistent symptoms that keep changing location, especially any neurological stuff,
clinicians need to dig deeper, consider Lyme, not just dismiss it as stress or random minor things.
Exactly. Don't dismiss the pattern.
And the challenges don't necessarily stop even after treatment, right? There's this post-treatment phase.
That's right. Post-treatment Lyme disease syndrome, PTLDS.
Okay. What does that involve?
It's a condition where profound symptoms like persistent brain fog, really debilitating fatigue that rest doesn't help, musculoskeletal pain, these either continue or even start after someone's finished the standard antibiotic course.
Even after the bacteria should be gone.
Yes. And the common pitfall here, standard Lyme tests might become negative after treatment. They show the bacteria is cleared. So clinicians often mistakenly assume these lingering symptoms must be psychological. It's in your head. Or maybe it's something else entirely unrelated.
That must be incredibly frustrating for patients, still suffering, but told there's no infection.
Immense frustration, even despair, because the suffering is real, but the tests say clear. But the crucial insight we have now from ongoing research, these symptoms aren't imagined. They're increasingly understood to be related to persistent neuroinflammatory issues in the brain, the nervous system.
So inflammation left over from the infection.
or perhaps even damage caused by the initial infection, even after the bug itself is gone. It's a complex post-infectious inflammatory response.
So how do you diagnose that?
The correct approach involves meticulously tracking the precise symptom timeline, specifically looking for those neurocognitive complaints, that deep fatigue, neuropathic pain that appeared or got worse after the initial antibiotics. You can't just rely on the now negative lab results alone.
It requires understanding the long-term effects, validating the patient's experience.
Absolutely. A commitment to validating what the patient is still going through.
Okay, moving on. Let's talk about fibromyalgia. This is another one that feels like it gets misjudged a lot. Dismissed even. People told their pain isn't real because it's invisible.
You're absolutely right. Fibromyalgia is characterized by that core triad.
Yeah.
Widespread chronic pain.
Often described like an ache.
A deep ache, yes. Or burning, throbbing sometimes. Plus profound non-restorative fatigue.
Meaning sleep doesn't actually refresh you.
Exactly. And just poor, disturbed sleep patterns in general.
Huge challenge and why it gets misdiagnosed. These symptoms aren't unique to fibromyalgia.
Right, the overlap problem again.
Big time. Depression, anxiety, chronic fatigue syndrome, RA, even just stress. They can all present similarly.
Leading to it being dismissed as just stress or all in your head.
Which causes immense prolonged suffering for patients who are experiencing very real physical pain and serious functional impairment.
And the lack of visible signs doesn't help. Definitely contributes to the dismissal. Makes it one of the most frustrating diagnoses out there for patients and for clinicians struggling to find an objective cause.
But here's where the lab tests get really interesting, almost counterintuitive, right? The fact that they're normal can actually be a clue.
Indeed. The paradox of normal labs is a crucial diagnostic piece for fibromyalgia. When patients come in with widespread pain and fatigue, doctors naturally order standard inflammation markers, ESR, CRP.
To rule out things like rheumatoid arthritis or lupus.
Exactly. Those tests measure general inflammation. What's crucial to understand about fibromyalgia is that, by its nature, these markers are typically normal. And that normalcy, counterintuitively, is itself a significant diagnostic clue. Think about our illustrative point, Maria, the 45-year-old teacher.
Right, battling exhaustion, body aching all over back, shoulders, hips, knees. Felt like a deep bruise. Sleep didn't help.
And every doctor visit, every blood test for inflammation, muscle enzymes, autoimmune markers, perfectly normal.
So doctors suggested stress, exercise, therapy.
Yeah.
Implying it was psychological.
Yes. But the profound insight here, the red flag for clinicians, is that this very normalcy, in the face of such debilitating, widespread, persistent pain, that is the clearest signal pointing towards fibromyalgia.
It challenges that idea that if you can't see it or measure it on a standard test, it's not real.
Precisely. It forces a deeper understanding. Chronic pain as a neurological thing, involving altered pain processing, not just inflammation or structure.
So no inflammation markers, but debilitating diffuse pain points to...
While classic GI symptoms like chronic diarrhea, bloating, abdominal pain, significant weight loss, they're definitely there in many cases. But a major reason celiac gets missed is because the symptoms go way beyond the gut.
It's autoimmune, triggered by gluten.
Correct. And the body's reaction can affect almost any system. We frequently see less obvious signs that completely mask the real issue for years. Symptoms get blamed on other things.
Like what?
Things like chronic iron deficiency anemia that just doesn't respond to iron pills because the gut isn't absorbing nutrients properly, unexplained infertility, recurrent miscarriages in men and women, low bone density, early osteoporosis, even in younger people.
Wow.
Skin rashes like dermatitis or piriformis, nerve damage causing tingling or numbness, even neurological stuff like brain fog and migraines.
So these systemic symptoms get attributed elsewhere, delaying the celiac diagnosis.
Significantly. It's vital to remember. Celiac disease is systemic autoimmune, not just a local gut problem.
And then there's a specific testing trap, something clinicians really need to watch out for.
Yes. This is a critical point. It trips up many clinicians, the IgA deficiency trap.
Okay, explain that.
When a patient gets a basic celiac blood panel, a primary test is often tissue transglutaminase IgA, or TTG-IgA. It looks for a specific antibody the body makes in response to gluten in celiac disease.
Standard procedure.
Right. But here's the catch. About 1 in 500 people have a condition called selective IgA deficiency. Their body just doesn't produce enough of that specific type of IgA antibody.
Ah, I see where this is going.
So if a patient has celiac and IgA deficiency, their TTG-IgA test will come back falsely negative.
Even though they do have celiac disease.
Exactly. It's like using a net with a specific hole in it for the fish you're trying to catch. You won't catch it even if it's there.
So what's the solution?
It is absolutely essential to always check total IgA levels at the same time as celiac serology, like TTG-IgA. If that total IgA is low or undetectable, then you need other tests.
Like what?
Tests looking for IgG-based antibodies, like DGP-IgG, or ultimately the gold standard, an endoscopy with a small bowel biopsy. That becomes necessary regardless of the TTG-IgA result if suspicion is high.
So take that example. Patient with chronic fatigue, anemia, maybe family history of autoimmune issues. TTG-IgA is negative.
A diligent clinician should immediately check total IgA if that's low. Suspicion for celiac should increase, not decrease.
It really hammers home that principle. Don't stop at one test, especially if the clinical picture doesn't fit the lab result.
Absolutely.
Yeah.
Especially in the nuanced world of autoimmune diagnostics.
Okay, irritable bowel syndrome, IBS. This one gets used as a kind of placeholder diagnosis sometimes, doesn't it, when nothing else is obvious? And maybe that label stops further investigation.
That's a valid and deeply concerning point. While IBS is a genuine, common functional GI disorder.
Characterized by chronic belly pain, altered bowel habits, but no structural issues.
Exactly. The problem happens when it's assigned too readily. Without thoroughly ruling out more serious things first, it can become this diagnostic bucket for unexplained GI symptoms, leading to, premature closure of the investigation.
So how do you tell the difference? What separates IBS from something more serious?
The critical differentiator lies in what we call alarm symptoms, absolute red flags. These indicate something much more serious than IBS might be going on. They demand immediate, deeper investigation.
Okay, like what?
Things like nocturnal diarrhea that actually wakes you up from sleep, unintended significant weight loss you can't explain, or any gastrointestinal bleeding, visible or microscopic.
Those are not typical for IBS.
Definitely not. Should never, ever be dismissed. Their presence has to trigger an urgent, comprehensive workup.
So what kind of deeper investigation are we talking about to differentiate IBS from, say, IBD?
Okay, as an illustrative point, consider specific lab markers. They can help differentiate right away. Elevated fecal calprotectin, that's a marker of gut inflammation, or an elevated C-reactive protein, CRP, in the blood systemic inflammation. Even subtle elevations matter.
And those would point towards inflammatory bowel disease, like Crohn's or ulcerative colitis.
Strongly suggested, yes, which are serious autoimmune conditions needing very different management than IBS. In true IBS, those inflammatory markers, typically normal.
But doctors might not order those tests unless the alarm symptoms are really obvious.
That can happen. But it's crucial to understand, even subtle elevations in calprotectin or CRP are significant. They're worth following. They indicate real inflammation that's just absent in true IBS.
So a thorough workup for persistent GI symptoms should always rule out IBD, celiac.
Absolutely. Especially if alarm symptoms are present, or if the symptoms don't perfectly fit the standard Rome 4V criteria for IBS.
The nuance is recognizing subtle doesn't mean insignificant.
Precisely. Especially when looking for serious conditions hidden by a generic IBS label.
Lupus. Another one that sounds incredibly hard to diagnose definitively. It overlaps with so much stuff.
Indeed. Systemic lupus erythematosus lupus. It's challenging primarily because of its extraordinary symptom overlap. It's often called the great imitator for a reason.
What kind of overlap are we talking about?
Patients might have this confusing mix. Chronic joint pain that moves around. Profound fatigue, totally out of proportion to activity. Various skin rashes could easily be mistaken for rheumatoid arthritis, fibromyalgia, psoriasis, even just a virus.
And it affects the brain, too.
Yes, the complexity deepens with neurological and psychological signs. Brain fog, memory issues, depression, anxiety. These can really muddy the waters. Might lead to misdirection towards purely psychiatric diagnoses when lupus is the real systemic cause.
And it varies so much between people.
Hugely. No two lupus patients are exactly alike. The presentation is broad, variable, often fluctuates, makes pattern recognition really tough.
Okay, what about the ANA test? Anti-nuclear antibody. That's the go-to screening test for autoimmune, right? But I hear it can be confusing.
That's correct. ANA is the usual, indispensable screening tool for autoimmune diseases, including lupus. But understanding the nuances is absolutely critical. It's a common source of misinterpretation.
How so?
Well, while a positive ANA is generally necessary for a lupus diagnosis, you usually won't have lupus with a consistently negative ANA. It is not sufficient on its own.
Okay.
A significant pitfall is that a positive ANA can show up in a fair number of perfectly healthy people. especially in low titers.
Leading to false positives or just confusion?
Both. A low titer ANA, especially if someone doesn't have specific lupus symptoms, it might not mean anything clinically significant, can cause unnecessary anxiety, more tests.
So what are the more revealing signs from testing?
It's not just a positive ANA, it's usually a high titer ANA, a strong positive, like 1.160 or higher. And crucially, that high ANA combined with the presence of specific additional antibodies, like anti-dsDNA, anti-double-stranded DNA, or anti-Smith antibodies. These guys are much more specific to lupus, carry much higher diagnostic weight, indicate a more definitive lupus-related autoimmune process.
So it's about the whole picture symptoms plus the right antibody pattern, not just any positive ANA. Can you give us an example? How does a careful clinician connect the dots when symptoms seem scattered?
Certainly. Let's use our illustrated point, Alex, 28 years old. Presents with a seemingly scattered array over months. Joint pain migrating from knees to wrists, that peculiar butterfly rash on the face flares in sunlight. And then, almost incidentally, a routine urine test shows trace proteinuria, protein in the urine, suggests kidney involvement.
Okay, separately, those could be anything. Rheumatology, dermatology, nephrology referrals.
Exactly. But a careful clinician, trained to look for systemic patterns, starts piecing them together. The combination, migratory joint pain, characteristic rash, evidence of kidney involvement, that pattern is highly suggestive of lupus.
Not three separate problems.
Right. It's recognizing lupus is systemic. It can hit almost any organ joints, skin, kidneys, brain, blood. So seemingly disparate symptoms often form a cohesive, complex picture viewed through that potential autoimmune lens.
That holistic approach is key for these great imitator conditions.
Vital. Looking beyond single symptoms to the whole patient's story, how systems interact.
Okay, next up, multiple sclerosis, MS. You hear about symptoms being dismissed as anxiety or stress, especially in young adults. That must lead to critical delays.
It is indeed, and tragically common. MS is complex, chronic neurological. The immune system attacks the myelin sheath covering nerves in the brain, spinal cord.
Disrupting communication between the brain and body.
Exactly. And its initial presentation. Highly variable, insidious, mimics lots of other things.
Like what kind of symptoms?
Transient numbness or tingling in a limb. Sudden, profound fatigue, really debilitating. Temporary vision problems, blurred vision, double vision, subtle balance issues. They're often vague, can fluctuate in intensity. So they're easy to blame on stress, anxiety, being overworked, just tired.
Especially in younger people who might not be taken as seriously.
That's a definite problem. Leads to significant delays in getting the right diagnostic workups. And the consequence of delay is huge. Early diagnosis, prompt treatment with disease-modifying therapies. That's essential.
To slow the disease, prevent more damage, preserve function long-term.
Absolutely. Preserve neurological function and quality of life. Delays really impact that.
So, if basic lab tests are, as you said, typically unhelpful here, offering few clues, where do clinicians find the evidence? What are the definitive diagnostic giveaways for MS?
What's fascinating here is that while standard blood tests don't help much, the clues get much clearer with specialized investigations. Looking directly at the central nervous system, the definitive giveaways primarily involve advanced imaging and cerebrospinal fluid analysis. MRI findings are crucial, yes. We look for specific white matter lesions in the brain and spinal cord. These lesions are areas where myelin's been damaged. They show up as bright spots on the MRI, their location, size, appearance, especially if new ones develop over time. That's characteristic of MS.
And the spinal fluid.
Second, detecting oligoclonal bands in the cerebrospinal fluid, the CSF. You get that via a lumbar puncture, a spinal tap. These bands are specific proteins that reflect inflammation and immune activity within the central nervous system. Shows the immune system is actively attacking the myelin there.
Okay, so MRI and CSF analysis are key.
They are. But here's a crucial insight. A careful, thorough, really skilled neurological exam can often pick up subtle signs of MS even before imaging gives conclusive proof.
Really? Like what?
A neurologist might detect minor deficits, vision field issues, coordination problems, reflex changes, subtle muscle weakness, sensation changes, things the patient might not notice or a general practitioner might miss.
Subtle tremor, maybe? Abnormal eye movements? Changes in gait?
Exactly. These are all clinical clues that guide the neurologist towards needing that MRI or lumbar puncture.
Emphasizes the value of clinical expertise. The art of medicine, not just the science.
Profoundly. Highlights the art alongside the science in diagnosing MS.
Hypothyroidism. Underactive thyroid. This sounds like another case where symptoms hang around despite labs looking normal, leading to misdiagnoses.
Precisely. Hypothyroidism is deceptively easy to miss, particularly its subclinical or early forms. It's frequently overlooked when the TSH thyroid-stimulating hormone level falls within that broad normal lab range. But the patient is still experiencing classic hypothyroid symptoms.
Like what symptoms?
Persistent, crushing fatigue not helped by rest. Unexplained weight gain despite no changes in diet or activity. Profound cold intolerance, even when it's not that cold. Dry, flaky skin. Constipation. Hair thinning or loss. Even cognitive stuff like depression, significant brain fog, memory problems.
And the problem is doctors might stop looking once the TSH is in range.
That's the inherent problem. They see the number within the reference range and don't consider the individual symptoms or look closer at the actual TSH number within that range or other related thyroid hormones.
Tell us more about subclinical hypothyroidism and why are those wide lab ranges such a persistent issue?
Okay, subclinical hypothyroidism is specific. The TSH level is elevated, the pituitary gland is working harder to poke the thyroid, but the free T4, the main active thyroid hormone, is still within the normal range.
So it looks mild on paper.
Seemingly mild, yes. But patients can be profoundly symptomatic, experiencing their whole spectrum of hypothyroid issues. The illustrative point here, and it's a big systemic issue, is the problem of overly wide TSH reference ranges labs use.
Different labs have different normals.
Exactly. What one lab calls normal, maybe 0.4 to 4.0 MIUL, might be seen as elevated or suspicious by another lab or expert. Or, more importantly, it might just not be optimal for a symptomatic patient. For instance, many endocrinologists, many guidelines now suggest a narrower, more optimal TSH range for healthy folks, often 0.5 to 2.5.
So a TSH of 3.5 might be flagged as normal by the lab.
But if the patient has debilitating fatigue and cold intolerance, that 3.5 could indicate a subclinical issue needing treatment.
Okay, so actionable advice for listeners.
If you, or someone you know, has persistent symptoms, cold intolerance, unexplained fatigue, hair loss, dry skin, even with a seemingly normal TSH result, it should prompt deeper, more targeted thyroid testing.
Looking beyond just TSH.
Yes, look at free T4, maybe free T3, another active hormone. Consider thyroid antibody tests like TPO antibodies. Explore the full clinical picture.
It's about treating the patient, relieving suffering, not just sticking blindly to a broad lab range.
That's the goal. Treat the person, not just the number.
Let's switch to adult ADHD, attention deficit hyperactivity disorder. This sounds like a remarkably common psychiatric misdiagnosis, often mistaken for other mental health conditions.
Indeed, adult ADHD is frequently misdiagnosed, often as generalized anxiety disorder or various mood disorders, depression, bipolar. Why? Because of significant overlapping behavioral patterns and symptoms.
How does it typically present in adults who come seeking help?
Adults with undiagnosed ADHD often report chronic restlessness, persistent difficulty concentrating, severe procrastination, poor time management, impulsivity in decisions, conversations, and significant emotional dysregulation, irritability, sudden mood swings.
I can see how that could look like anxiety or depression.
Very easily misinterpreted that way, leading clinicians to prescribe meds or therapies that don't hit the core neurobiological issue of ADHD. And that constant internal struggle to focus, organize, control impulses creates immense stress, feelings of inadequacy.
Which then contributes to actual secondary anxiety and depression.
Exactly. Further obscuring the underlying ADHD. Creates this complex web of symptoms.
So if it's so easily mistaken, and unlike many things we've discussed, there's no blood test, no scan, no objective lab marker for ADHD, how do you diagnose it accurately? That sounds uniquely challenging.
You've hit the nail on the head. That is the unique diagnostic challenge for ADHD. There is no lab test, no biomarker, which means history is everything.
The diagnosis relies entirely on a really comprehensive clinical interview.
And gathering incredibly detailed historical information. Not just from the patient. Often, you need corroborating info from family, parents, siblings, partners. Even old school records can be useful.
Looking for patterns across their whole life, starting in childhood.
Meticulously.
Yeah.
Clinicians have to inquire about the entire life trajectory, looking for patterns that began in childhood and persist into adulthood. Key areas to ask about: past school performance, academic history.
Were there consistent struggles? Organization, assignments, focus in class, even if they were intelligent?
Yes. Reports like smart but underperforming, lacks motivation, common red flags, also childhood behaviors. Developmental patterns. Was there evidence of hyperactivity, inattention, impulsivity back then, even if undiagnosed?
Because ADHD is neurodevelopmental, symptoms must have been present since childhood.
Correct. Though they might look different in adults. Childhood hyperactivity might become internal restlessness, a constant need for stimulation, and crucially, a deep dive into how challenges manifest in structured versus unstructured environments.
Ah, that contrast can be revealing.
Highly revealing. Someone with ADHD might excel in a highly structured, engaging job with clear deadlines, external accountability, thrive under pressure. But that same person might struggle massively in unstructured settings, managing household chores, personal finances, pursuing hobbies requiring self-directed effort, organizing their personal life.
That stark difference is a diagnostic beacon, helps differentiate from, say, anxiety, which might be more pervasive.
Exactly. It helps differentiate. It requires a true deep dive into the patient's whole life story, looking for those consistent, lifelong patterns.
Okay, our final condition for this deep dive, endometriosis. You called this a classic for misdiagnosis, leading to years, sometimes decades of suffering. It sounds incredibly prevalent yet under-recognized.
It's an incredibly challenging and prevalent condition for misdiagnosis. Often an average diagnostic delay of 7 to 10 years, sometimes much longer from when symptoms start.
And what exactly is endometriosis?
It involves tissue similar to the uterine lining, the endometrium, growing outside the uterus, most commonly on ovaries, fallopian tubes, pelvic tissues. But it can show up almost anywhere. This misplaced tissue acts like the uterine lining, thickens, bleeds with each menstrual cycle.
But the blood has nowhere to go.
Exactly. Unlike menstrual blood, which exits the body, this blood gets trapped. Leads to chronic inflammation, scarring, adhesions, and immense pain.
And the mislabels are common?
Rampant. Patients report severe, often incapacitating pelvic pain, chronic bloating, debilitating cramping into the back, legs, painful bowel movements or urination, and they're frequently dismissed. Symptoms get blamed on IBS because of the abdominal discomfort, or recurrent UTIs due to bladder pain.
Comes from a lack of understanding that severe pelvic pain tied to the cycle isn't normal.
Precisely. It's not normal. It's not just bad periods, especially pain that severely impacts daily life.
What are the diagnostic challenges? Especially with routine labs and standard imaging. Sounds like there's an invisibility factor.
You're exactly right. A significant invisibility factor contributes hugely to delays. The diagnostic challenges are multifaceted. Routine labs, generally unhelpful. No blood markers to definitively diagnose it. Can't screen with a blood test.
What about scans? Ultrasound, MRI?
Standard imaging like transvaginal ultrasound or MRI often miss it. Unless there are large ovarian cysts, endometriomas, or really extensive, deep, infiltrating lesions. The smaller, more widespread implants, which can still cause terrible pain, often completely invisible on scans, even with a skilled radiologist looking.
That invisibility must contribute to the delay. Doctors reluctant to believe what they can't see.
Greatly contributes, yes.
Yeah.
However, there's a most crucial diagnostic clue, a key tip-off clinicians must recognize.
Which is?
Pain that distinctly tracks the menstrual cycle, or significantly worsens with ovulation.
So not just mild cramps, debilitating pain.
Debilitating pain interfering with daily life, especially if it starts days before the period, continues throughout. Or pain intensifying during ovulation. That's highly suspicious for endo.
That specific cyclical pattern isn't typical for IBS or UTIs.
Not characteristic of them, though. They tend to have less predictable pain patterns relative to this cycle.
So it really requires a detailed, empathetic patient history. High suspicion based on that cyclical pain.
Absolutely. And the gold standard for definitive diagnosis remains laparoscopic surgery, visually identify and biopsy the implants. But recognizing those cyclical pain patterns can significantly shorten the journey to that point. Spare years of unnecessary suffering.
Okay, so we've covered a lot. Lyme, fibro, celiac, IBS, lupus, MS, hypothyroidism, ADHD, endometriosis. What does this all mean for you, our listener, whether you're a healthcare professional trying to improve or just someone navigating the system? After this deep dive, what's the ultimate takeaway?
If we connect this all back to the bigger picture, the overarching takeaway is, I think, profoundly clear and critical. Many conditions get missed, not because symptoms aren't there, but because they're vague, non-specific, overlapping. And crucially, because those initial lab tests often look normal.
It's not just coincidence, it's a pattern, rooted in how we approach diagnosis sometimes.
Right. So we have to reiterate that core message. Normal isn't always reassuring. Its true meaning depends entirely on the patient's individual context, their unique symptoms, the full clinical picture.
A lab result in the normal range, but maybe right at the edge. or slightly off alongside persistent symptoms.
That's a crucial clue. It shouldn't be dismissed as coincidence or an anomaly. It's often that first whisper of a deeper issue needing diligent investigation.
This raises an important question, then, for all of us. What can we do?
The actionable conclusion, I think, is to encourage listeners for themselves, for people they care about, to adopt a mindset of critical inquiry, persistent advocacy, meaning not stopping at the first explanation given for persistent or puzzling symptoms, especially if they're debilitating or worsening.
Questioning patterns, like if symptoms are recurrent, cyclical, shifting unexpectedly.
Exactly, like we saw with Lyme and endometriosis. And perhaps most importantly, trusting and meticulously documenting the detailed personal timeline of symptoms the patient provides.
Patients know their bodies best. Their experience is key.
They're the experts of their own bodies, their narrative, their lived experience, often the most profound diagnostic tool available, guides clinicians more accurately than a single test result often can. When labs don't match the story should always prompt further, deeper investigation.
Fostering a collaborative, persistent, problem-solving approach where the patient's voice is central.
That's the ideal.
Well, this deep dive, we really hope, has empowered you, our listener, to maybe understand these diagnostic nuances better and potentially advocate more effectively for thorough evaluation, whether it's for yourself or someone you care about. Recognizing these patterns, understanding these common pitfalls, it can truly change lives, transform years of suffering into a path toward diagnosis, toward effective treatment. As we close out this deep dive, maybe consider this provocative thought. What might you now question about symptoms you or someone you know have experienced? Or maybe how might this information change how you approach medical information, how you engage in diagnostic processes moving forward?
The importance of critical thinking, continuous learning, persistence in the face of these diagnostic challenges. It just can't be overstated. Never underestimate the profound power of careful observation, meticulous documentation, and most crucially, the patient's own deeply felt story.
Thank you for engaging in this deep dive with us. Join us next week as we bring you new and amazing topics, continuing our mission to provide you with insights that truly matter.